Connected by purpose, driven by passion. Welcome to the Spark Live webinar series, where we gather to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities. Keep up to date on all of Children's Healthcare Canada's webinars, events, and announcements. Sign up for our Spark News e-bulletin by visiting our website at childhealthcan.ca and follow @childhealthcan on Instagram, X, and LinkedIn. Now, on to today's webinar.
Hello, everyone, and welcome to a special edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, Director of Research and Knowledge Mobilization at Children's Healthcare Canada, and your co-host for the next hour. Thank you for joining us today for the webinar, Advancing Youth Suicide Prevention, Learning Across Borders. I'll begin by acknowledging that Children's Healthcare Canada operates on the traditional and unceded territory of the Algonquin Anishinaabe peoples. We recognize and deeply appreciate their historic connection to Ottawa. And today, Ottawa is home to Indigenous peoples from across Turtle Island. Children's Healthcare Canada is committed to forging new and deepening existing relationships with First Nations, Inuit, and Métis peoples, and we're grateful for the opportunity to share this land as we work to measurably improve children's health and healthcare from coast to coast to coast. Our conversation today matters. Despite being among the world's wealthiest nations, both Canada and the United States rank near the bottom among high-income countries in youth suicide, according to the UNICEF report cards. Families, communities, and health systems across both countries are feeling the impact, and we know we must do better. Today's webinar highlights how coordinated system-level collaboration is moving the needle. I'm delighted to co-host this session with our partners at the Children's Hospital Association in the US. They're our sister organization. And I'm co-hosting this session with Heidi Baskerville. And Heidi, over to you.
Thanks, Paula. Hi, everyone. I'm Heidi Baskerville, Vice President of Mental Health at the Children's Hospital Association. And today, we're so pleased to co-host today's session. At CHA, our work brings together children's hospitals across the U.S. to improve care, share evidence, and advance national initiatives, including the Preventing Youth Suicide National Collaborative that we launched in 2022. With 39 participating hospitals, the collaborative has transformed suicide risk identification, assessment, and care through the development of shared protocols, data-driven improvement, and culture change across emergency, inpatient, and community settings. And today we're really excited to hear from our partners and highlight some really promising Canadian models that are driving better outcomes through coordinated and community-centered strategies.
Today, we're honored to be joined by two exceptional leaders in youth mental health. Dr. Jennifer McTaggart is the Clinical Director of Acute Mental Health Services at McMaster Children's Hospital and creator of the Youth with Complex Suicide Needs Protocol. The Youth with Complex Suicide Needs Protocol provides a coordinated cross-agency approach to supporting children and youth who are at high risk for suicide and whose needs exceed the capacity of typical care models. It enables any community stakeholder to initiate a collaborative process to create and implement a shared safety plan. Dr. Daphne Korzak is the chair in Child and Youth Medical Psychiatry and the director of Children's Integrated Mood and Body Depression Program at Sick Kids. She's the principal investigator of Canada's first multi-site randomized control trial focused on suicide prevention following emergency department presentations. Her leadership is advancing new interventions and building capacity across regions. Over to you, Heidi.
Together, we're going to explore how coordinated systems from hospital to community can better identify, support, and follow up with youth at risk, and what shared learning across borders can teach us about scaling what works. I want to start off with just sharing a couple of lessons that we've learned through our own work here at the Children's Hospital Association before I turn it over to Dr. McTaggart. I think one of the things that surprised us all was how many different challenges we were going to have in data collection, and that so much of the effective data that we needed to inform how we were going to apply effective approaches to screening and assessment and treatment were on data sources outside of the control of children's hospitals. And so one of the continued commitments that we have is to, in fact, streamline the way that we work with external partners to better structure our data collection systems to really help us be more effective in this space. I think the other thing that perhaps we knew but didn't really understand the extent of which it was going to affect our work in this space is how much our hospital team members in places like the emergency department or on medical inpatient units had a lot of apprehension about how they were going to screen and assess for suicide risk. And that just because they were trained to be, for example, emergency medicine providers, didn't mean that they had a comfort level or a training to support this kind of work. And that in the same way that we were having to think differently about how we partnered externally on any number of things, that we also needed to think about how we were creating safe spaces for staff to talk about what they were scared about, what they needed by way of training in order to ensure that they had the tools and resources that they needed to do this work beyond the already comprehensive approaches to medical training that they already were provided. So with that, I want to hand it over to our partner, Dr. McTaggart.
Thank you, Heidi, and thank you, CHC and CHA, for having me. Let me get my PowerPoint up. Hopefully you guys see my PowerPoint. I'm going to be speaking to you today about the Youth with Complex Suicide Needs Protocol, which is a protocol we developed in our region. But first of all, when I told my son this morning that I was going to be doing a presentation, he said, "Can you say hi for me?" So here's hi from Carrie. He said he wanted to be famous. So here he is. Back on topic, I will be talking about the who, what, where, when, why of YCSN, Youth with Complex Suicide Needs Protocol, and wanted to start it with a bit of a background into what problem were we trying to solve when we created this protocol. So acute mental health inpatient units are often regarded as places where kids disappear for a while. The admission criteria sometimes are unknown. There's very little collaboration with the community during the admission, and youth are discharged, at best with some engagement, but often with very little awareness in the community. And we really felt like this wasn't the best care for these kids. And what we realized as a community was that we were concerned about the same number of kids, the same high-risk kids. So in hospital, when I'm concerned about someone, it also means the school's concerned about him or her, and this community is concerned, and there's high service use. And so we realized, like, these are the same kids we're talking about. We've got to be able to do better. So this protocol developed out of a grassroots initiative to better support those high-risk youth. So it was created in 2019, and what we wanted to do was create this coordinated, comprehensive approach to care for youth who have been identified as high risk for suicide. And we really bring the community together quickly to jointly decide on risk factors that we want to decrease and protective factors that we want to increase. So our target population is children and youth under the age of 18, and that's one of our limitations given our system, who have been identified as being high risk for suicide and who have some complexity to their presentation that would force us to come together or mean that we needed to come together to think about things differently. So high risk for suicide could either be acute high risk, suicidal ideation, plan, and intent, or chronic or acute on chronic. And the additional complexity that we wanted to make sure we were serving was those who maybe continue to have suicidal ideation and behaviors despite being involved in evidence-based treatment. Perhaps there's some psychosocial complexity in terms of cognitive functioning or street involved. There's a discharge within 30 days or an impending discharge from hospital about which the community is concerned. Perhaps there's high service use and multiple presentations to the emergency or admissions. Or they're involved with a bunch of people who just feel like they don't know what's going on as a group. So what the protocol does, key features are that we come together quickly. Within 1 week, we'll pull together people across sectors and we make decisions in the moment. So this is really the key piece, and that's why our membership is important. I didn't want another meeting where we kind of talked in circles. I wanted it to be action oriented. It's quick and it's timely. We are collaborative, we're inclusive. If someone new comes onto the team, we're making sure we're including them. And a real key piece is that it's co-chaired by hospital and community. So really needing the hospital to be a driver on this and for help them to understand why it's important for the hospital. And also to partner with the community to co-chair this initiative. And our members come from our hospital, both acute and ambulatory, and our emergency department, school boards, crisis agencies, the police, our shelter systems, child protection, community mental health, primary care, and probation services. And we continue to add new members as our population for who gets on YCSN evolves. So each participating membership agency has a primary and a secondary representative. So these are the people who are knowledgeable about the protocol and they're capable of making administrative and or financial decisions in the moment. So we need the key people there who can move things forward timely. And so each agency has these primary and secondary representatives, and they're responsible for training about the protocol in their agency, representing their agency at these meetings, inviting the important people from their agency who need to be there, and distributing the minutes. How does the protocol work? So any community person who's involved with the protocol who meets the target criteria can activate the protocol. And so we do this based on consent. And there's an asterisk. If there is imminent risk that we need to mitigate, we will come together quickly. But in the 6 years we've been doing it, I think we have only consulted without consent once, and then quickly got consent to be able to continue to have these conversations. Activation must be done by the activating agency's protocol representative to the protocol chairs. And so we're wanting to make sure that this ensures that they're appropriate for the protocol, that we're minimizing any confusion about who's doing what, and it allows us to be more efficient. So the initial YCSN meeting is a consultation. It's really us coming together to say, hey, does this person meet our criteria? And it is a consensus decision. We vote as YCSN representatives. And the outcome of that first one, where we really talk about the suicide risk in terms of ideation, behaviors, past behaviors, any risk factors that might increase, obviously, risk, a lack of protective factors, we're either going to activate YCSN or we're going to say, you know what, it's not quite YCSN, but hey, look, now we have all the people around the table who we need to partner for community meetings. Our meetings are only half an hour. They can be weekly, bi-weekly, every 3 weeks as we start to maybe reduce risk. And we always start with the youth current suicide risk. So who has the most information about this youth current suicide risk that lets us drive the conversation? Then we're reviewing what we know of in terms of the risk factors and the protective factors and adding anything in that we need to target. It's very action oriented. Okay, here's what we know, what can be done, and who's going to do it. If we need to have clinical focused meetings, which might happen for sure, then we will schedule those separately with the people who need to be there. Our common targets that we might identify in terms of our risk factors or protective factors might be restricting access to means, making sure that the house is safety proof, making sure that caregivers are able to follow through on safety plans. Perhaps they're not engaged in evidence-based treatment. Maybe there's parent-child relationship difficulties, not attending school, which increases isolation and disconnection, a lack of a gender-affirming care, that transition to adult services that we know is so difficult, increasing pro-social peer relationships, increasing functional activities like exercise or what is good for everybody in terms of improving sleep. Our documentation is standardized, pretty brief and short. What's the issue we're working on? What's the update? What can we do and who's going to do it? And we close the protocol. We have to keep things really tight to be like, okay, this person might continue to be at risk, but do they continue to meet the YCSN criteria? So we will close the protocol if they no longer meet the criteria, if we've seen an evidence of risk reduction, or the youth turns 18 and transitions to adult services. Impact and next steps. So there has been a very positive community response to this protocol. It is recognized in the community as a key collaboration. What I think came out of it, whereas before there were these tensions across the community, like, why can't the school get that kid safe? Why is hospital discharging them right away? And there was all these judgment about what each of us were doing. Now we sort of all own these kids. There's this shared responsibility to support these youth and these families, which has allowed us to have increased collegiality, increased trust without judgment. We'll stretch our mandates in order to support. So if a youth is in live-in treatment in the community and the high-risk behaviors are burning out and potentially breaking down that placement, we'll talk about how maybe hospital is now needed in order to give them a rest, stabilize, and make sure that that placement can continue. So being able to have really open and honest conversations about how we can support each other in the ultimate hope of supporting the youth. And I think a byproduct that we didn't actually expect is that we now have key contacts across the sector to leverage for non-YCSN youth. So now I have key contacts in all these sectors or agencies to be able to say, hey, this is happening. What are you hearing about this, to be able to collaborate and coordinate care. What we've learned is that we have to adhere really closely to the target population criteria. If we stray anywhere in there, I think that creates fatigue in the system, because this is action-oriented and it is for those high risk kids. We want to make sure we're not misusing the protocol for other reasons. So really adhering to that criteria, making sure those meetings are action-oriented with accountability. So we are always leaving there with takeaways as to who's going to do what. The standard action-oriented documentation has been very helpful. We need to make sure we're involving adult services as soon as the youth starts to turn 17, where we can, because we know that transition to adult services, especially in mental health, it feels like children are just falling off a cliff. And so really needing to start to build those relationships and make that transition sooner. And a real practical thing is we would try to schedule these meetings as we needed, and we realized we just needed a standing time. This protocol is, we don't have any formal dedicated resource to it. It's myself and my co-chair in the community sending out the agenda and following up. So it really needs to kind of run tight to be as efficient as possible. We expanded, so we started this protocol in Hamilton. which is where McMaster Children's Hospital is, but we're a regional hospital. So we were able to expand to other communities in 2022 through great word of mouth and advocacy to get this protocol expanded. And we want to continue to expand it to our nearby regions. And we have presented the protocol to other areas across the country to see, is this something that might work well in other communities to support kids. I'm going to leave you with some quotes from our community partners. So our school board rep says YCSN creates a team approach that maximizes the strengths that each partner organization and mitigates some of the system limitations. From my perspective, this is the gold standard of community care and collaboration. Our police rep says the most significant impact of YCSN is the multi-sectoral risk intervention team. The collaboration between police and community care providers is a unique partnership in Ontario, setting it apart from other municipalities that offer similar services. Our child protection colleague, timely information sharing among agencies is critical to ensure that everyone receives and understands the latest updates on youth with complex needs. This cohesive approach supports informed decision-making and the development of coordinated care plans. We're no longer working in silos. So thank you very much for having me. I look forward to answering any questions you might have after, and I will pass it over to Daphne, Dr. Korzak. You're muted, Daphne.
I got it. Oh my gosh, it's only been 5 years. Hi everyone. Thanks so much for inviting me. Thank you, Dr. McTaggart. What an interesting presentation, and I learned a lot myself too. Okay, so I'm going to try and share my screen, and hopefully the right screen. Okay, do you see my presentation? Okay, great. That's only one
Yes, we
person
do.
can see, so that's
Thank you.
great. Thanks. So I'm shifting gears a little bit. I'm going to talk a little bit about the randomized control trial that we're just wrapping up in Ontario. That was mentioned sort of in the introduction. This is sort of talking a little bit, sort of taking a step back from, Dr. McTaggart sort of talking about the more complex kids, the more high risk acute kids that have maybe been through this or the system a few times already. I'm going to be sort of talking a little bit more from the sort of prior to that, the more general sort of population of kids coming to the emergency department. So I'm going to start a little bit with talk, and this is an audience that I think is probably familiar, but just to highlight why it's important to talk about. We have seen this is sort of pre-pandemic. We saw in Ontario and real increases, particularly in the rates of self-harm by girls. The girls are in open circles there. A general sort of trend toward increase in boys as well. But you can see that, self-harm in girls is really increasing over the sort of 10 years before the pandemic. And then, for us, we were really interested in what happened with the pandemic because if you remember at that time, there was a lot of discourse about it. Were kids all right? Were they not all right? Were they coming more often? Were they not? And what was happening to their mental health. And so we wanted to look at this quantitatively. And so we, together with some colleagues, looked at this kids before and during the COVID pandemic and looking at the rates of emergency department visits for attempted suicide, self-harm, and suicidal ideation. It's a meta-analysis that came out in the sort of toward the tail end of the pandemic. And looking at about 11 million emergency department visits across 18 countries around the world. And we found that overall, even despite accounting for that linear trend that had been increasing before the pandemic, we saw a significant increase in suicide attempts during compared with prior to the COVID pandemic, sort of globally. But I think that's something that many emergency departments were sort of anecdotally had a sense of and feeling already. I think what made it more notable was that, all other visits, there was a sharp decrease in all other visits, about a 32% decrease in kids coming to the emergency department for all other reasons. And so, this was already a concern. But of course, we saw rates were higher during the pandemic in girls and older adolescents. And the problem for acute care providers is that we don't have any evidence-based standardized treatments for acute safety concerns. And, that was something that I think was driving a lot of anxiety among our emergency department colleagues, but also among parents, youth, people working in mental health, outpatient clinicians as well. So I was just going to highlight that this was also the case in Canada. I showed you the global data, but this is Canada in particular. And this again is sort of prior to and during the pandemic. And you can see the girls here in the solid, sort of the more dashed lines, and the boys in the dotted lines here. So really seeing this increase in the girls in particular during the pandemic. So this trial is looking at the SAFE program intervention. It's an intervention that we developed at Sick Kids. We started it on our inpatient unit originally, and then adapted it and have been testing it in outpatient and now emergency department settings. So this is a program that was co-developed with youth and with parents and with frontline clinicians. And it was really based on the most common problems, concerns, questions, underlying diagnoses that clinicians were finding and that parents and youth were experiencing when they had a child who was admitted with a suicide attempt. And what we wanted to do was really standardize the approach on the inpatient unit, but also, work to standardize approach in the outpatient setting, because I started my life as a pediatrician before I became a psychiatrist. And when I worked in a pediatric emergency department, and a child came in with acute asthma exacerbation or diabetic ketoacidosis, we had very clear algorithms, and they were sort of accepted across every site. Wherever that child went, they would get the same treatment. It didn't really matter whether it was weekday or weeknight or holiday or who the nurse or frontline clinician was. That treatment was going to be the same. And so we really wanted to have some kind of a standardized approach. So that was something that we'd really been hearing from patients and families a lot, that what they received in terms of treatment depended a lot on where they went, and sometimes even time of day, or weekday, holiday, or weekend. So this was a program that, as I mentioned, it's modular, it's standardized, it has some flexibility so that it can be tailored to specific youth problems. If it's gender identity, it might be more related to particular family situation. It might be related to school difficulties. So there's some flexibility within it, but the core modules and principles are the same. And it's based, as I mentioned, based on what we were hearing from youth and families. And one of the things that we heard is that when a youth was admitted to the hospital, when a youth came with a suicide attempt, that they were really struggling, but very often their parents were really struggling too. They either had no idea about their child's suicidality, or they really didn't know how to help them. Often there was some conflict in the family. Sometimes that conflict was the precipitant of that particular self-harm or suicide attempt. And they really felt like they needed some help as well, parents. And so we wanted to include family members in this, because they are the person of support living at home. And vast majority of the time, they're desperate to be able to help their child in a way that's going to be heard, and a way that's going to be helpful. And this particular protocol targets suicidality directly. So it's not necessarily targeting just depression or just anxiety, although those are components of modules within the program. It really is talking about safety and suicidality directly. So We had developed this, and we had an individual workbook, we had a parent workbook, and a therapist guidebook to try and standardize this, and then wanted to know, was this going to be acceptable to patients and families? Would it be effective? And the more information about the protocol is here for anyone who's interested. It's also published in clinical trials. So after piloting it as an open pilot in our crisis clinic within sick kids, and then piloting the randomized control trial in terms of the methods, we decided to look at whether this might be effective. We really wanted to test whether it was going to be effective or not in decreasing suicidal ideation, decreasing self-harm and suicide attempts. And this is the trial that has recently just wrapped up at 4 sites, community and academic centers, Sick Kids, Alberta Children's Hospital in Calgary, McMaster Hospital, you've just heard from Dr. McTaggart about in Hamilton, and Trillium Health Partners, which is quite a large community hospital in the suburban Greater Toronto area, Mississauga, to see, how do we, if we have something like this, how do we scale it to other centers and test it at the same time? Just to give you a sense of it, this is for teenagers who come to the Emerge with an acute safety concern. They have a parent who is willing to participate. So this particular treatment model does work. The theorized mechanism of association is through improving parent-child communication, decreasing conflict. So the parent is important to this particular treatment. And you can see they were randomized to either receive the intervention, which was weekly intervention for 6 weeks, or an enhanced treatment as usual, where we had case navigation and follow-up on a weekly basis to ensure connection to aftercare. We just finished our recruitment. We have randomized 335 youth now, and we are just turning to our analysis soon. So I think one of the questions that was asked, that in particular, what I had been asked to share was thinking a little bit about implementation barriers and facilitators and lessons learned when trying to scale something like this and trying to implement it in a new setting. For us, when we think about some of the implementation barriers, one of these was looking at mental health research in the ED with a high-risk population. So most of our sites really, they may have had some experience with mental health research in the ED to some extent. Certainly there was a lot of ED-based research, but with this kind of high-risk population, not as much. And so, there wasn't a clear process necessarily for how to embed the protocol within the ED workflow. So identifying, the key people within the ED, like the intake coordinators, was pretty critical. The next is sort of the integration of research between our own emergency department and outpatient mental health services. And so really working between the two teams was something that we had to improve. So, looking at communication, strengthening communication with the outpatient programs to try and help ensure families were consistently informed about the research study. They were, supported in a collaborative way. It didn't seem to compete with other treatment as usual types of offerings or opportunities. So that's something that we worked on quite a bit. And then, of course, the other issue for us is, this is not like outpatient recruitment where you might have eyes on who is coming to clinic, who is going to be seen in an appointment for, days or weeks or longer in advance, and have the opportunity to sort of plan around that. This was, quite spontaneous. We wouldn't know who was going to be coming to the emergency department and whether they would be interested in research and so on. And so recruitment after hours, and particularly it was important to try and address those kinds of barriers to make sure that kids were recruited in a timely fashion before they left the window of recruitment. So how did we handle these, or what was helpful? I think you've heard some of this already through Dr. McTaggart, so it's really a common theme. Collaboration was really key. And so active engagement and partnership with the emergency department intake and triage was really key, sort of key in helping us integrate research participation, opportunities into the intake. We established strong partnerships. The co-PI of this study is an emergency physician who helped to champion it within the emergency department. And we really found that being in person was very important. So, we would present to the ED rounds, we would try and check in with personnel, but we really saw an increase, an uptake of the study when we began to do that in person. And that was a little bit challenging during COVID, especially. But as soon as we started to have more in-person visits, that really improved the rapport between all of the various teams and the connections, and it really helped to increase the uptake. The next, I would say, is trying to use the medical charting system and integrate as best as possible. I think that's something that we found very helpful. So, in our hospital and several of the hospitals, although not all, in the study use this particular medical charting system, and being able to run reports and reduce reliance on sort of busy clinical staff was pretty helpful. It helped the coordinators identify who might be eligible, coordinate the steps sort of in real time. And we found that where there was a real-time referral system, we saw a lot more interest and more timely kind of uptake and recruitment. Definitely sites, once they started to use the medical charting system as one point of integration, we also saw really an increase in enrollment rates. And then the last, again, huge facilitator, as I mentioned, was building a strong rapport with the clinical staff as well. So the physicians, the crisis workers, and really increase engagement so that they could understand what was being offered, how this could potentially augment their treatment plan, and ultimately inform our care overall, sort of with respect to one potential treatment for these youth and parents. So, what we've learned, sort of, I've alluded to a lot of that already. When implementing in a new site, we learned very quickly that we needed to understand the specific site very early in the study process. Really getting a good sense of what each hospital and each emergency department flow is with respect to their workflow, where their strengths are, trying to understand their triage processes, and identifying early sort of the key intake personnel and the treatments that youth in that particular site tend to move toward. And so in one of the sites, there was a brief stay unit, for example, for mental health patients. And so understanding that brief stay unit was a place where many of the patients with suicide attempts might go for a brief period of time was really important. And we actually found that was a really productive place for enrollment into the trial. So, really, that sort of leads to the next lesson learned, which was that tailoring that recruitment really made a big difference. So a single recruitment model really did not work across these sort of diverse systems. And so being flexible, one site that we had the study running in during the time of the study had a lot of challenges with fluctuating emergency department teams, some shifting in their outpatient structures. And so really being flexible in terms of how to track folks, looking at administrators, for example, who sometimes could be really key in being consistent and following a youth through from the ED onward was quite important. So next lesson I wanted to sort of mention was looking at consistency in training resources across the site. So there was sort of this balance between wanting to be flexible within each study, but also making sure that the training was clear, the training was easy to learn, that it was reproducible. And so whether it was scripts or cross-site training to ensure that the protocols were implemented with fidelity and decrease some of the variability with respect to individual study staff was really important. So whether it was about onboarding training, onboarding time, to really minimize that and get people up and running in a way that was that ensured sort of consistency and fidelity. Again, that engagement and partnership was really, really very important. And again, where possible, we're a big country, and Calgary to Toronto is not an easy drive. It's quite a distance, and so we would fly out to Calgary and have some in-person meetings. Really finding that a lot of value in being in person to really boost engagement, at least in that setting annually. I think that also helped with us understand the way that we understood specific struggles in that site. So, for example, in one site, when a study therapist was approaching their full capacity, we could really understand what was happening with that particular therapist and their caseloads to help prevent the bottlenecks, sort of anticipate the trend and work to improve that situation collaboratively. Those in-person visits, I would say, they often led to some concrete operational improvements, really reinforced the collaborative commitment to the study. And then lastly, again, integrating with the chart system, we felt was really important, particularly when recruiting from the ED. It really helped teams to be able to quickly identify eligible patients in real time, processes track where youth and families are in the process, really helpful for linking participants to research. And so in that way, EPIC for us was very helpful in coordinating with other services or studies. So I think I'm going to leave it there for now. I hope that we're okay for time. And I just want to acknowledge just a large team that has helped with this study already. Thank you. And I'll
No doubt. It's always a team effort, is it not? Thank you so much, Jennifer and Daphne, for your thoughtful presentations and for the important work you're leading. Your insights give us not only a deeper understanding of the challenges, but a clearer sense of what meaningful action can look like. Thank you also to our co-host, Heidi, and the Children's Hospital Association for joining us. Now, I see our members have questions that have come in, and I'm going to take a moment to get them sorted. Tarita asks, for Jen, the collaboration and working outside silos is needed and a much needed progress. I'm wondering if there is also focus anywhere to include PANS or PANDAS educated doctors, as this is often an overlooked, misdiagnosed, treatable medical condition. Suicidal ideation and school refusal is often prevalent with these children.
Thanks for the question. Not PANDAS educated specifically for YCSN, but I agree that it is an often overlooked presentation, and this complex interplay of medical and post-infection and psychiatric mental health symptoms. So not specifically for the protocol, but I think is point well taken in the sense of, are we having enough education on what that looks like and how that might play out on pediatrics as well as in mental health.
Another question from Trita. Are there protocols for patients where family violence is disclosed? She comments that we know the domestic violence rates are increasing and appears to be a lack of standard screening or tailored approaches for children experiencing family violence, as well as an overall overlooking of the ACEs, and the impact of trauma on brain development. As time goes on, is there space to integrate these into standard protocols?
Yes, it's an excellent question. So there's a bit to unpack there. Let me think. So in terms of the family violence, do we have protocol? I mean, it certainly becomes something that we do at assessment. What people do when they get, information on it, I think is not standardized. So that I think I think that's where we work in silos a lot, especially in that domain. But we do have another community protocol in our region for youth who are violent or aggressive that is similar to YCSN in terms of pulling people together and making sure we have the correct people at the table. I think the ACEs thing is huge in terms of exposure to adverse childhood experiences. We have done some preliminary evaluation on our unit and saw, double, triple fold national average number of adverse childhood experiences for our kids on inpatient units. So, and we know the downstream effects on medical and physical and mental health. And the cost of that. So I completely agree that there needs to be more research and more practical appreciation for the impact of childhood experiences on brain development, on families, on physical and mental well-being.
Thank you. Jennifer asks for Daphne. What's the modality for the I Am Safe delivery? Is it in person, by telehealth, or by phone? And I'm going to add, are there other details that would help others implement it in their context?
Yeah, thank you for the question. And I would say that what we had envisioned was changed a little bit by the COVID pandemic, which we did not anticipate. I noticed that Dr. McTaggart's protocol was first created in 2019 as well. And we received funding for our large study in the spring of 2020. And so up until then, this had been an in-person protocol. We had always run it on the inpatient unit where people were in person. Then we ran it through the emergency department, again, where people were in person. And suddenly we could really not do that, nor could we delay the treatment. So we had to start to run it virtually. And so that's a little bit of a shift from the way we had intended it. Once we started to open it up again, sort of our society started to open up again, we started to give patients and families the choice between in-person and virtual. And we found quite a mix. I would say families would often and youth would often say they preferred to be seen in person. But it wasn't always possible. So we're just looking at how it ended up shaking out. Where possible, we would try and do at least one or two of those sessions in person. And then the others virtual. That we never did it by telephone. The one thing I would say is that even when virtual, though, the youth and family member would be in the same physical location.
Okay.
So it wasn't a case of somebody was participating at school and somebody was participating at work or something like that.
Right. And when you say you're checking to see how it all sort of worked out, is that to compare outcomes based on modality?
Yeah, if we have enough in-person sessions, we certainly will. We also ask patients what they preferred and what they were interested in. I mean, it can be difficult to to get around to make time once life
Sure.
opened up again. It can, logistically, it can be difficult on a weekly basis, but that we did certainly have some parents and kids who were really committed to in person, and our therapists were all happy to accommodate that.
Oh, wonderful. This one's for Heidi. Heidi, can you share how other providers should be thinking about data collection design in a way that can most effectively support the growth of this work?
Yeah, I mean, I think from the beginning, giving a whole lot of intentional pre-plan to where you're getting data such that you're thinking about who is going to need that and how accessible it is really critical to the foundational, the build. And so if you're creating sort of a data scenario that only applies within a very limited context of your healthcare setting, it's going to be really difficult to see it expand both into community-based settings and or to be utilized and picked up by other providers. So we would just say that one of our valuable learnings from the beginning is to think about what is the kind of data that you need and how easily is that going to be accessed by a whole lot of other people who need it to be able to serve this population.
Wonderful. And how, Heidi, does what you've learned from Jen and Daphne resonate with your experiences down south?
Well, I think there are so many commonalities with respect to what we're learning in how to serve this population. And I know that we have so many of our member hospitals on today who are going to be excited to follow up with each of you in ongoing conversations about what they're doing and how they can partner directly with each of you and your teams to advance their work. So this time has been invaluable together.
Oh, wonderful. I'm so glad it's helpful. And our final question for Jen, how would the graph that says issue, update, action, who will do it be used in practice? Would it be an ongoing chart, an individualized care plan for each person? How have you used it?
We use it as our standard documentation template, but so those headings are standardized, but the issues are individualized and tailored to that particular use risk factors. Always number one is suicide risk.
There.
So we're always couching it in current risk. So the first issue is always suicide risk, and then we'll get an update, anything that needs to be done from an action perspective and who's going to do it. And then we tailor it based on their risk factors and protective factors that we want to target. We do carry them from week to week, right? So if not attending school is one of the risk factors, we'll always talk about that every week. If we're continuing to need to restrict access to means, we will always talk about that. If we're trying to create a plan with the hospital and the emergency department, that will always be until we can kind of get some stability on that. So we use it as documentation template, but also sort of like treatment planning in that sense to help us stay focused.
Wonderful. Thanks. Over to you, Heidi, for the closing.
That's the end of our time together today. And I want to thank Jennifer and Daphne so much for sharing your time and your expertise. We want to thank all of our audience members for participating, and we'll look forward to engaging together more often in the coming new year. We know how busy everybody is, and we hope that everyone departs with some practical knowledge to bring back to your organization. It's always great if you're able to watch live, but we want everybody to know that for colleagues who perhaps weren't able to join us, that the recordings of the session will be made available after the fact to share. And on behalf of Children's Healthcare Canada and the Children's Hospital Association, thank you all for being part of this important discussion. We hope you'll continue to stay connected with both organizations and all of the resources that we have to share. And we wish everybody a happy holiday season and a happy new year. Thanks very much.
Thank you all.